Good afternoon, students. Today is Saturday, 13 February 2021. This is our second video of the week. We have one more video before the exam, and that will probably be for you on Tuesday. And I should tell you that the sample questions are posted. They have been for several days now. I hope you've had a chance to look them over. Remember that some, many, most, or all of them may appear in the exam, so make sure you at least remember the correct answers. You can think of it as free points for any of those questions that appear in the exam. Today we're going to spend, maybe 45 minutes or so doing the second third of the article by the Emanuels, and then on the final lecture on Tuesday next week, we will wrap things up by covering the third, if you will. So let's get back to it. Before we get into the new material, let me do a little summary of what we've covered so far. You may recall that we've discussed 4 different models or ideals of the physician-patient relationship. Eventually, the Emanuels are going to argue that one of them is preferable to the others, but that'll come next week when we finish things up. But let me go ahead and sketch the 4 models that we've discussed, beginning with the paternalistic model. And remember, I have posted a handout that restates the chart that the Emanuels include in their article. I made it bigger and I put some footnotes in it. The paternalistic model views the doctor as a parent or guardian of the patient. The physician decides, with little or no input from the patient, based upon the physician's assessment of the patient's good. So think of that one as doctor knows best. The second model is called the informative model. This is somewhat of an extreme, at the other extreme of the spectrum. Here, the doctor may be thought of as a technical expert, or as I like to think of it, a mechanic. The physician provides information to the patient about the diagnosis, the prognosis, the various therapeutic options, their costs and benefits, and so on. Once the information is provided, the doctor leaves it to the patient to decide which course of action to pursue. The third model is the interpretive model. This one gives the doctor a greater role. The doctor here can be thought of as a counselor or perhaps as a midwife. Now, all patients have values. Some patients have thought through their values at great length, others not so much. Here, the doctor needs to discuss with the patient what the patient's values are and try to elicit from the patient what those values are, and then apply them to the facts of the situation. The doctor's job is to engage in discussion with the patient. The aim of that discussion is to elucidate or bring out into the open, the patient's values or wishes. And then they together will make a decision about what to do. So the doctor's role is not to supply the values, but to help the patient understand the values that he or she already has. The fourth model, and I'll give you a hint, this is the one the Emanuels end up arguing for, is called the deliberative model, because the doctor and the patient will deliberate together just as a jury deliberates before rendering a verdict in a criminal or civil case. So here, the physician provides information, of course, and discussion. And if the patient hesitates or resists, the doctor will seek to persuade the patient to undergo a certain treatment or type of therapy. The physician will not be limited by the patient's own values. The doctor will, of course, consider them and take them into account, but the doctor will feel free to bring into play other values, including social values or broader moral values. For example, altruism. The doctor may try to persuade the patient that a particular course of action is preferable, not merely because it promotes the patient's best interests, but also the interest of other people. In this case we're about to discuss, other women who may find themselves with breast cancer. So that's a quick sketch of the 4 models. There's a section of this essay entitled Comparing the 4 Models. I want to say a few words about that. According to the Emanuels, all 4 models promote patient autonomy. All of them do. The only difference is they have a different understanding of what patient autonomy amounts to or comes to. In the paternalistic model, autonomy amounts to little more than assenting to whatever the physician decides. In the informative model, autonomy is much more significant because there the patient eventually makes the decision even if the doctor doesn't agree with it. The patient gets the last call, gets to make the call. You could say it's the customer is always right theory, at least if you want to view the patient as a customer. Now, the Emanuels, I may have mentioned this earlier, the Emanuels actually mention and discuss very briefly a 5th model of the physician-patient relationship. They don't take it as seriously as they do the other 4. In fact, they're quite dismissive of it. It's discussed on page 2222. And here's what they say about it. They say, and they call it the instrumental model. In this model, the patient's values are irrelevant. The physician aims for some goal independent of the patient, such as the good of society or furtherance of scientific knowledge, unquote. So here, unlike the other 4 models that we've been discussing, the patient's values don't come into play at all. The doctor is using the patient as a mere means to some greater or further end, maybe some social end. So the doctor is treating the patient as a thing to be used for the sake of some greater good. Now, obviously, this is morally questionable. And sad to say, there are many examples historically in which physicians and researchers have used patients in just this way. The infamous Tuskegee syphilis experiment, for example. Now, you can look up the details of this on your own. There's probably a fairly accurate Wikipedia page. But this one involved physicians refraining from treating men who had syphilis, and I think they were all black men in Tuskegee, Alabama. The physicians misled them into thinking that they were being treated for their syphilis, but in fact, at least some of them were not being treated. The goal of the physicians was to see the course of the disease over time. So that is obviously a morally highly questionable activity that those physicians were engaged in. They were using those men as a mere means to their own ends or to the ends of society. They may have been altruistic in their motivation. The physicians and researchers may well have been trying to produce the greatest overall good by understanding the progression of syphilis. Unfortunately, morally unfortunately, they failed to disclose what they were doing to their patients. Another example involves hepatitis. In the infamous Willowbrook hepatitis studies or experiment, the inmates of a mental institution were used in experiments without their consent, without their knowledge, to trace the course of hepatitis. So these 2 cases, Tuskegee and Willowbrook, are much discussed in the literature of biomedical ethics. They're considered terrible abuses of medical authority or biomedical authority. And many people cite them as what must never be done again. There are also, as you may know, experiments that were done by the Nazis, Nazi doctors in Nazi Germany. Much of the research that was gleaned from those experiments was published. And to this day, there's a big debate going on among biomedical ethicists about whether the findings of the Nazi doctors should be made use of. And there's an argument on both sides. On the pro side, you might argue that the research is done and over. We can't change the past. The knowledge that was acquired in these experiments might prove useful and might help alleviate pain and suffering for humans today and tomorrow. So why waste the findings of this research? Another argument on the other side, however, says that we should refuse to make use of the knowledge acquired in these Nazi experiments, if only to discourage future researchers from engaging in the same kind of more immoral conduct. Right? We should simply boycott it and say, on principle, we refuse to make use of this research. We don't want to dirty our hands by making use of research that was obtained or that was conducted in immoral ways. So what do the Emanuel say about this instrumental model, the fifth model? They say on that same page, this model is not an ideal, but an aberration. So they're condemning this model. That's why they don't say much more about it. If this is a model of the physician-patient relationship, it's one we should condemn and refuse to participate in the future. So from now on, going forward, let's just keep those four initial models in mind. Okay, paternalistic, informative, interpretive, and deliberative. And we're going to set aside the instrumental model. Now that doesn't mean I won't test you on it. I'm sure I'll have at least one question about it on the exam. What I'm saying is that going forward, we're going to ignore it. Now that we've discussed it, we have no need to discuss it any further. Okay, let's get to this medical or this clinical case, and I want to spend really the rest of today discussing it. Remember that Emanuel's specialty in medicine is breast oncology. So he's an expert in what he's about to discuss. I'm sure he's the one who came up with this case, and it's probably based not on just one of his patients, but maybe a composite case with features from different cases that he has handled. In this case, and he discusses this starting on page 2222 of the essay, he says the case is about a 43-year-old pre-menopausal woman who has recently been diagnosed with a breast mass, or a breast mass has recently been discovered. Now, initial surgery discloses a carcinoma, which is a form of cancer. But there's no evidence, fortunately for this woman, no evidence of metastatic disease. Now, in case you don't know what that means, I looked it up. Here's the dictionary definition of metastasis. It means the spread of cancer to other parts of the body. So what that means now is that this 43-year-old woman is diagnosed with breast cancer, but it's in the early stages. It has not yet spread to other organ systems or to other parts of her body. Now, the Emanuels point out something interesting, and it may have made you wonder. The patient, they say, is recently divorced and has recently returned to work as a legal aid. You may wonder, what does that have to do with anything? Well, some of these models require that the physician try to integrate the treatment with the patient's life and activities. So the fact that the woman is recently divorced may suggest that she has no caregiver, and that may affect the course of treatment that's prescribed for her. And it may be relevant in other ways as well. The fact that she has returned to work as a legal aid suggests that she has a job, she needs to work to pay her bills, and that will also affect the course of treatment. The doctor who's attending will need to figure out a course of treatment that will allow her to continue to work, if that's at all possible. So facts that may seem irrelevant at first can turn out to be relevant after all when you start applying the various models. So here's the question: what should the physician say to this patient? What should the physician say to this patient? How should their interaction proceed? And the answer to that question will differ depending on which of the four models that we're discussing. So I'm going to read and discuss each of these four models as applied to this particular clinical case. So here's what I'm reading from. I have my copy of the article here, and I'm reading from page 2222. You'll notice the heading entitled A Clinical Case. They proceed on this page and for most of the next page to apply each of the four models to the facts of this case. And I think this is the way a better way, a good way for you to understand the similarities and differences of these four models. So let's get started. I'll read a paragraph and then we'll pause to discuss it. I will emphasize certain things. I may add something here and there or ask a question. If I'm puzzled by something, I'll express it to you. In the classroom, of course, we would have discussions, but this technology that we're using, where I lecture and you watch and listen, doesn't lend itself to that. So I'm going to have to kind of raise issues that I think my students, you, may have in mind as we go along. Okay, let's reread the facts. I gave you a synopsis, but let's read the facts as they are presented by the Emanuels. Okay, here we go. To make tangible these abstract descriptions or models and to crystallize essential differences among the models, we will illustrate the responses they suggest in a clinical situation, that of a 43-year-old pre-menopausal woman who has recently discovered a breast mass. Now, she herself may have felt the mass, been concerned by it, and gone to see a doctor. Surgery reveals a 3.5 centimeter ductal carcinoma, which I believe means cancer in one of her ducts or perhaps lymph nodes. Oh, I'm sorry, it's a ductal carcinoma with no lymph node involvement. That is estrogen receptor positive. So there's some medical jargon in this description. Chest röntgenogram, which is X-ray, I believe, bone scan, and liver function tests reveal no evidence of metastatic disease. So the first concern once the diagnosis of carcinoma was confirmed is to find out whether it has spread to any other organs of her body or any other bodily systems. And the answer is no, it has not. So I'm sure she's grateful for that. The patient was recently divorced and has gone back to work as a legal aid to support herself. What should the physician say to this patient? And we're going to ask that same question 4 times. So let's begin with the paternalistic model. That's the one we discussed first, although it's not listed first on the handout, so don't get confused by that. Okay, so put yourself in the mindset of the paternalistic model. Remember what the basic features of that. Doctor knows best. Here's how that would go. In the paternalistic model, a physician might say, quote, "There are 2 alternative therapies to protect against recurrence of cancer in your breast: mastectomy or radiation. We now know," this is still the doctor talking, "we now know that the survival with lumpectomy combined with radiation therapy is equal to that with mastectomy." So pause right there. Lumpectomy means removing not the whole breast, but just the lump that is contained within it. And mastectomy means removal of the entire breast. So the doctor points out to her that as far as research currently shows, recurrence, that survival with lumpectomy and radiation combined is equal to that of mastectomy. So obviously, a woman would prefer, other things being equal, to have only the lump in her breast removed to having the whole breast removed. So the only question is the addition of radiation such that she would then prefer to have the entire breast removed? Okay, so the doctor continues saying the following: because lumpectomy and radiation, remember those are being combined, because that offers the best survival and the best cosmetic result, it is to be preferred. I have asked the radiation therapist to come and discuss radiation treatment with you. We also need to protect you against the spread of the cancer to other parts of your body. Turn the page. Even though the chance of recurrence is low, you are young, and we should not leave any therapeutic possibilities untried. Recent studies involving chemotherapy suggest improvements in survival without recurrence of breast cancer. Indeed, the National Cancer Institute recommends chemotherapy for women with your type of breast cancer. Chemotherapy has side effects. Nevertheless, a few months of hardship now are worth the potential added years of life without cancer. Unquote. Interesting. That's all the Emanuel say about the paternalistic model. But notice, the thing that should strike you is the lack of participation of the patient. The doctor is having a monologue rather than a dialogue. Now, I'm not suggesting that in the real world, a doctor who's acting under the paternalistic model would never elicit comments from the patient, because in the middle column on this page near the bottom, the Emanuels say, lacking the normal interchange with patients, these statements may seem contrived, even caricatures. Nevertheless, they highlight the essence of each model and suggest how the objectives and assumptions of each inform a physician's approach to his or her patients. So the Emanuels are not suggesting that this is all the physician would or should say. It's a caricature, right? It's just a one-paragraph summary of the things that would happen in a paternalistic interchange. But notice, still, the doctor just gives a monologue with little or no contribution from the patient. And that's characteristic of this model, isn't it? The doctor knows best. The doctor is thinking things through based upon what the doctor takes to be her welfare, her well-being. And the doctor is not trying to implement her values at all. Remember, the patient values in this model are objective. The doctor is making use of what the doctor takes to be the objective well-being of this patient, not her subjective well-being or what she wants or wishes or wills. Okay, so that's an example of the paternalistic model. Now, still using this woman as our example, let's go to the informative model. There's a little bit of a longer paragraph this time. In the informative model, a physician might say the following, quote, with node-negative breast cancer, there are two issues before you, local control and systemic control. For local control, the options are mastectomy or lumpectomy with or without radiation. From many studies, we know that mastectomy and lumpectomy with radiation result in identical overall survival, about 80% 10-year survival. Lumpectomy without radiation results in a 30% to 40% chance of tumor recurrence in the breast. The second issue relates to systemic control. We know that chemotherapy prolongs survival for premenopausal women who have axillary nodes involved with tumor. The role for women with node-negative breast cancer is less clear. Individual studies suggest that chemotherapy is of no benefit in terms of improving overall survival, but a comprehensive review of all studies suggests that there is a survival benefit. Several years ago, the NCI suggested that for women like yourself, chemotherapy can have a positive therapeutic impact. Finally, let me inform you, notice the word, the Emanuel's put that word in, let me inform you, this is the informative model, that there are clinical trials for which you are eligible to evaluate the benefits of chemotherapy for patients with node-negative breast cancer, which is what she has. I can enroll you in a study if you want. I will be happy to give you any further information you feel you need. Now, once again, we had no input from the patient. I mean, this is a caricature. Keep that in mind. Notice a couple of things about this. First of all, it's heavy with jargon, isn't it? Some of the terminology made use of by the doctor is probably unfamiliar to this woman, and maybe she would need to ask questions about terms that are unfamiliar to her. So this would be part of the model. The woman asks questions, the doctor answers them. The doctor's job is continually to provide relevant information, either unsolicited or at the request of the woman, the patient herself. Now, notice the doctor did not try to make a decision. In fact, the doctor didn't elicit her values at all, did he or she? By the way, is the doctor assumed to be male in this example? We would know if masculine pronouns were used. I'm not sure, and I don't want to take time to look. I'm going to continue saying he or she, him or her, until we see a pronoun. If the Emanuels use a masculine pronoun, then I'll use the masculine pronoun myself. But I don't want to be sexist about it. So notice that the doctor doesn't try to elicit the patient's values. And that's because the doctor won't be applying the values at all. The doctor is there to provide information, and the patient will apply his or her values, in this case her values, to that information and make a decision about what course of treatment to undertake or undergo. So this is a good example of the informative model that we've been discussing, that we discussed the other day at great length. Right? The doctor provides information, the patient applies his or her values to it and makes a decision. It's the mechanic model, right? The patient goes to see the doctor who has expertise and knowledge and skill, and the patient wants to know all the options, what their costs and benefits are, and ultimately the patient will make a decision. It doesn't have to be right away. The patient may well go home and think about it for a few days before contacting the doctor and informing the doctor of her decision. Okay, 2 more to go and we'll be done for today. And then Tuesday we'll wrap things up by covering the rest of the chapter or the article. All right, the third model is the interpretive model. This is the midwife model. The goal of the doctor here is to bring out into the open the patient's values, which may be inchoate. Remember that word, inchoate? It means unformed or undeveloped. So the doctor has a more involved role in this model. The doctor needs to ask questions that are designed to bring out into the open the patient's values so that they can be discussed and applied to the facts of the situation. Ultimately, the patient will make the decision, but it will be a better informed decision because the patient has been encouraged to think through and articulate his or her values by the doctor. Notice it requires a certain amount of skill on the part of the doctor, doesn't it? Doctors are, in their training, probably take few, if any, courses in eliciting patient values. So I would suggest that some doctors are better at this than others. Some of them may be quite bad at it, others quite good. I don't know that there are courses in medical school that teach bedside manner or how to interact with patients and that sort of thing. I can tell you that in graduate school for philosophy, which I attended for 5 years, at no point in my graduate studies were we ever taught how to teach. There was no discussion whatsoever about teaching. It was simply understood or assumed that if you got a PhD in philosophy, you would be competent to teach. But there was no training offered or required at all. And I think that explains why some philosophers are brilliant teachers and some are probably atrocious. And then, of course, you have everything in between. Teaching in a discipline like philosophy is something that's left to the professor. And some professors of philosophy take it very seriously. They take pride in their teaching. They're constantly learning new techniques. They're trying to develop ways to get through to their students and inspire their students and so forth. Other professors maybe don't care so much about teaching and don't take any steps at all to become better, more effective teachers. So I brought that up because just as philosophers get no training in teaching, I suspect that doctors get little or no training in how to interact with their patients, and especially in how to elicit patient values. It is something that can get better over time, right? The more you do something, the better you get. So a doctor who's been practicing medicine in the clinic, in a clinical situation for many years, is probably pretty good by then at eliciting patient values. But I suspect that early on in a doctor's career, that may be more difficult, and maybe the doctor does a poorer job of it. And as in the case of philosophy, some doctors may take great pride in their ability to interact with patients and help them make better decisions. And other doctors may not care much at all about that. So let's move on to the interpretive model. It's in the first column of page 2223 near the bottom. The interpretive physician might outline much of the same information as the informative physician, then engage in, guess what, discussion to elucidate the patient's wishes, and conclude as follows, quote, "It sounds to me as if you have conflicting wishes. Understandably, you seem uncertain how to balance the demands required for receiving additional treatment, rejuvenating your personal affairs," remember she's recently divorced, "and maintaining your psychological equilibrium." So a breakup of any kind, but especially a divorce where the marriage lasted many years, is traumatic, as you can imagine, as some of you may know firsthand, either because you have gone through it or your parents or parents of a friend. So this woman is obviously in a state of grief, perhaps. She's trying to rebuild her life, and so on. The doctor is well aware of that and is trying to take that into account in the discussion. The doctor goes on to say, "Let me try to express a perspective that fits your position. Fighting your cancer is important, but it must leave you with a healthy self-image and quality time outside the hospital. This view seems compatible with undergoing radiation therapy, but not chemotherapy." So it's therapy with radiation, but not chemicals. "A lumpectomy with radiation maximizes your chance of surviving while preserving your breast. Radiotherapy fights your breast cancer without disfigurement. Conversely, chemotherapy would prolong the duration of therapy by many months. It would take longer. Further, the benefits of chemotherapy in terms of survival are smaller and more controversial." So that one's a little more iffy. "Given the recent changes in your life, you have too many new preoccupations to undergo months of chemotherapy for a questionable benefit. Do I understand you? We can talk again in a few days." That's very different. I hope you can see that approach is very different from either the paternalistic model, doctor knows best, or the mechanic model, the informative model. the doctor is much more concerned this time to integrate, I believe that word was used, to integrate many different considerations, some of them personal in nature. So the doctor's trying to get a feel for what this woman's life is like and what her own values are. The doctor's not imposing anything on her, right? He or she, I'm sorry, the doctor is trying to elicit, and that's why at the end the doctor says, "Do I understand you?" The doctor is trying to reconstruct her values. Notice early on the doctor said, "Let me try to express a perspective that fits your position." The doctor is taking all these facts about the woman's life and trying to reconstruct or rebuild an integrated life where she can work, where she can deal with her emotional or psychological grief at the breakup of her marriage, where she can cope with the treatment that's going to be prescribed for her, and so on. So the doctor is much more involved than in either of the other two cases. And the patient is also involved this time, right? In the informative model, the patient ultimately makes the decision, but the doctor has already just recited all of the information, provided all the information. Okay, notice the doctor wants her to have some time to think things through. We can talk again in a few days. So the doctor says, the doctor realizes, I've just bombarded her with a lot of things to think about, and you can't process all of this instantly or quickly. She needs some time, maybe a few days, and then when we talk again, she will come at the discussion with a more thoughtful approach. She will have thought through all the different aspects of the discussion she just had with the doctor. All right, one more model, the deliberative model. Remember, this is the one the Emanuels end up favoring or preferring. And so we have to watch out. We have to make sure they don't bias things in favor of the deliberative model by describing it in more glowing terms than the others. Okay, so I'm just warning you, keep them honest by watching to make sure they're not engaged in rhetoric, manipulative rhetoric, using glowing or favorable terms. Okay, the deliberative physician might begin by outlining the same factual information as before, engage in a conversation to elucidate the patient's values, but continue as follows. Remember, in the deliberative model, the doctor will not hesitate to bring in values that do not come from the patient, either the doctor's own values or, more likely, prevailing social values or moral values, or the values of other patients like this one. So here's what the doctor says. It seems clear that you should undergo radiation therapy. Now, stop right there. The word should jump out at you. Right? We didn't see the word should in any of the other models, did we? And that suggests that the doctor is engaged in persuasive reasoning or language here, right? You should. I suggest that you should do the following. All right, so look for other words like that, argumentative words, should, ought to, and so on. It seems clear that you should undergo radiation therapy. Why? It offers maximal survival with minimal risk, disfigurement, and disruption of your life. Okay, so the radiation therapy does not require mastectomy. The issue of chemotherapy is different, fraught with conflicting data. Balancing all the options, I think the best one for you is to enter a trial, a clinical trial, that is investigating the potential benefit of chemotherapy for women with node-negative breast cancer. Wow, stop right there for a moment. The doctor is suggesting that she enter a clinical trial, an experiment, with other experimental subjects, other women, there will, as you know, be a control group and an experimental group, and the research protocol will require administering a treatment to the experimental group that is not given to the control group, and then over the course of time, they will be observed to see what differences arise or exist. Now, the doctor is now going to give reasons in support of that decision. The doctor is saying, here's the course of action that I think you should engage in, and here are my reasons. So this is like a philosophical argument, isn't it? The doctor is going to try to persuade her by giving her reasons why she should follow one course of action and not others. Okay, first, the doctor says, it ensures that you receive excellent medical care. Now that one is focused on her, isn't it? That's not focused on others, but on her. Excellent medical care for her. At this point, we do not know which therapy maximizes survival. So the doctor is being honest. We are ignorant of this, we in the medical field. In a clinical study, the schedule of follow-up visits, tests, and decisions is specified by leading breast cancer experts to ensure that all the women receive care that is the best available anywhere. So the first of two reasons being given by the doctor why she should undergo radiation, why she should enter into a radiation trial, is that it will give her excellent medical care. So it's a self-interested reason why she should do it. Second, a second reason to participate in a trial is altruistic. Now let me pause and explain that. Altruism is concern for others, and often it comes at the expense of the self. So an altruist is a self-sacrificing individual. Right? An altruist is someone who jumps on a grenade in a war situation to sacrifice him or herself for the sake of the other members of the platoon, or perhaps innocent civilians. That's altruism. It typically connotes some degree of self-sacrifice for the sake of others. So let me begin again. A second reason to participate in a trial is altruistic. It allows you to contribute something to women with breast cancer in the future who will face difficult choices. Over decades, thousands of women have participated in studies that inform our current treatment practices. Without those women and the knowledge they made possible, we would probably still be giving you and all other women with breast cancer mastectomies. Now, this is interesting because it almost sounds like the doctor is putting her on a guilt trip. The doctor seems to be saying, you yourself are the beneficiary of decisions made by other women in the past. And because you're a beneficiary of what other women have chosen, you now have a debt or duty of gratitude to them to participate in this clinical trial. And by the way, knowledge that we glean or discover from this clinical trial will then help women down the road in the future. So that's an interesting argument that he or she is making, right? It connects the past, the present, and the future, right? You're here now in the present. You are the beneficiary of what women in the past have done. I don't know which side, I think it was this side. And if you choose the clinical trial, you may well end up benefiting women in the future, right? So you can join this parade of women who have been altruistic. You can feel proud of your participation and of your sacrifice, however it may turn out to be. All right, continuing. By enrolling in a trial, you participate in a tradition. That's what I was just describing, this tradition of altruism, in which women of one generation receive the highest standard of care available but also enhance the care of women in future generations, because medicine has learned something about which interventions are better. Continuing, I must tell you that I am not involved in the study. If you elect to enroll in this trial, you will initially see another breast cancer expert to plan your therapy. I have sought to explain our current knowledge and offer my recommendation so that you can make the best possible decision. Very interesting, isn't it? You can see how that model differs very much from the other three. It's similar to the interpretive model. The main difference is that in the interpretive model, the doctor was still trying to apply the patient's values to the decision. In the deliberative model, the doctor takes into account the patient's values, of course, but also other values that are moral in nature or social in nature. The doctor is trying to appeal to her sense of altruism. And notice at the end, the doctor says, as if to say, I don't get anything out of this, right? I'm not encouraging you to enter the trial because I'm part of the trial. I'm not. You'll have other doctors and other researchers to deal with, not me. I think what the doctor is doing there is to try to show her that the doctor, him or herself, isn't benefiting in any way through the research that will be published as a result of the trial. And why would that redound to the benefit of the researcher? Well, people who publish articles develop reputations as researchers or even good researchers. So what this doctor is saying is this: if you enter the clinical trial, I won't be part of it. I won't have my name on the publication. It won't enhance my reputation in any way. I'm getting nothing whatsoever out of it, not even a better reputation as a researcher. So the doctor is trying to say, don't think I'm trying to persuade you for self-interested reasons. I'm not. Okay, the next section is entitled The Current Debate and the Four Models. I just have a couple of things to say about that and we'll be done for the day. The Emanuels point out that over time, since at least the late 60s and 70s, there's been a movement toward greater patient autonomy, or what we might call sovereignty. The goal of that movement is to increase choice and control for the patient, to increase the amount, the degree of choice and control. This has gone too far, the Emanuels seem to be saying, right? We've got to stop this movement in its tracks. It's gone too far. It may have been a good thing to give patients more control than they had under the paternalistic model, but we've gone way beyond the point of reasonableness. We've gotten into unreasonable territory here. We need to come back, right? Think of it as a pendulum. A pendulum swings back and forth like this. So at one time, the pendulum was over here. Doctor knows best. The Emanuels say that we've now swung over to way over here to where the patient runs the show. Right? The informative model has taken over. And what the Emanuels want is they want the pendulum to swing back and maybe in the middle area right here. Not all the way back to the paternalism again, but more of a balance where the physician and the patient play equal roles in decision making. The trend has gotten so bad, they suggest, that the whole terminology of medicine has become business-like, right? Physicians are now called healthcare providers. That's a business term. Healthcare provider. It makes doctors and nurses seem like glorified providers of a service or a good or service in the marketplace. Patients are sometimes referred to as healthcare consumers. So business terminology has crept into medicine, and the Emanuels think that's unfortunate Right? We need to stop talking about doctors and their patients as though they were vendors and purchasers. Right? That's not appropriate in medicine, they are claiming. So the informative model has swung the pendulum so far that we are now thinking of medicine in terms of a business relationship or a commercial relationship. And that's bad, they think. We now have an emphasis on patient rights. Patients are said to have rights of various sorts in the course of their treatment. Patients now have what are called living wills. It's like a regular will is where upon your death, your property is distributed in accordance with your will. Your will, right? What you will to occur. It's related to willpower, right? An act of will. So with regard to property, you think things through. How do I want my property distributed upon my death? You perhaps go see an attorney who drafts wills. You tell the attorney what your wishes are, and the attorney drafts a document. Upon your death, the document is complied with or executed. A living will functions in the same way, except it doesn't distribute property. It makes medical decisions for you when you can no longer make such decisions. So suppose you lapse into a coma or become senile. If you have drafted a living will, you will have specified a course of treatment for yourself. What you're saying is, if I should fall into a condition where I'm no longer competent to make my own decisions, I wish for the following to be done to me or for me. That's called a living will. And you can draft a living will of your own if you wish. The state of Texas, if you're a resident of Texas, you can draft such a will. You can give a copy of it to your doctor or doctors. You can carry a copy in your vehicle in case you are in an accident. And it's designed to carry out your will with regard to medical decision making. And that's a form of patient autonomy, isn't it? That gives patients control and choice over their own medical treatment when they can no longer do so because of some mishap or misfortune that has befallen them. There are also things called a power of attorney. A power of attorney is similar to a living will, except that instead of describing what treatment you want when you become incompetent, it designates a person to make decisions for you or in your behalf. So I may draft a legal document called a power of attorney, and I may say that should I become incompetent, I want my wife or husband or lawyer or other family member to make decisions for me. So it's typically a loved one, someone trusted, trustworthy, and someone you trust. So those are two ways patient autonomy is being protected. And those things did not exist 30 or 40 years ago. Right? Living wills and medical powers of attorney have come into existence only after this movement began for patient rights in the late 60s, early 70s. So it's been less than half a century. What else? There is now a movement called the Right to Die movement. The idea here is, and we're going to be discussing this as our next reading. As soon as the exam is over, we're going to read a New Mexico Supreme Court case on this topic. But the idea is that patients who are terminally ill have a right to end their lives, even though the state in which they live may oppose it. In fact, it may criminalize it. So the right to die is the legal right to end your life or have assistance in ending your life. That's what's called physician-assisted suicide. So these are all part of the movement for the past half century to give patients greater choice and control over their medical care. Okay, so let's stop there. We have left ourselves about a third of this essay to discuss next week. I'm thinking it'll be Tuesday because I have an ethics lecture that I want to get done on Monday, and I'm trying to do one lecture each day instead of two, primarily to save my voice, but because I have other things to do as well. So your lecture will be posted probably Tuesday, but there's a chance it'll be posted on Wednesday. And don't forget, our exam is on Thursday next week, the 18th, and the window for taking the exam will be open from 8 in the morning on Thursday until 8 in the evening. The exam itself, however, is only 75 minutes in length. So once you go into Canvas and get started, you better click along, because in 75 minutes it will close and you'll be stuck if you haven't answered all the questions. I think it's enough time. It's the amount of time I've always given my students in class to take a similar exam. So it should be fine, but don't sit there and stare at a question for 15 minutes because that might prevent you from finishing. Okay, have a great weekend, and I'll see you one more time before the exam, Tuesday, possibly Wednesday. Take care.